How to live for 100 years without heart attack may be surprising to some of you, but it is going to be a reality. All of us know chronological aging is inevitable in the long run, but biological age is different because it represents how much your body has aged over the years. Biological aging can be postponed and longevity increased. Like chronological aging, AHCVD is also inevitable in the long run, but AHCVD, like acute myocardial infarction, can be postponed. So why we are so much interested in postponing acute myocardial infarction, besides the conventional reason that it is a deadly disease, in our country, the problem is premature CAD in India has become a new entity, and you can see lots of celebrities have died with acute myocardial infarction in young age. 30% of the heart attack occur before the age of 40 years, and those who are not known, many of them pass away every day without being noticed. So young Indians are more vulnerable to heart attacks, and this is an example. We encounter, at least in our hospital, 2 to 3 cases between the ages of 20 to 30 years, and that's why the interest in this topic. So this is story of a 23-year-old male second-year engineering student seek consultation with a physician of retrostatin burning of 2 hours duration. The physician took ECG, it shows changes, referred him to our hospital. He developed cardiac arrest in the OPD, revived and sent to the cath lab, and you can see the proximal LAD is totally occluded. Angioplasty done, you can see the artery has been opened up, the ECG reverted to virtually normal, and he's doing well. So at age 20 years, acute myocardial. The second example. So at what age prevention of ACVD and MI should start in India is a very complex problem and an unresolved issue. What age we should start? Case number 2, female, 41 years, prolonged chest pain. You can see ST segment depression in multiple leads. AVR ST is elevated, and left main stem disease suspected. And you can see the angiogram. Left main is totally occluded. Artery opened up. Angioplasty done, patient recovered, and look at the amount of atherosclerosis in young female, extensive atherosclerosis on IVUS. So all of us know acute myocardial infarction usually develops due to disruption of a vulnerable plaque in the artery. So long as the plaque is intact, nothing happens. The moment plaque gets disrupted, as you see, thrombogenic material comes out of this plaque, thrombus forms, artery occluded, and the area supplied by this artery, myocardium undergoes necrosis, and you develop acute myocardial infarction. So how could we minimize this process? Either you minimize atherosclerosis so that the plaque is not there or is very stabilized, or you can decrease thrombogenicity of blood. Decreasing thrombogenicity of blood for a long time is dangerous because all these drugs have very side effects. The concept you have to remember while you are talking of prevention of acute myocardial infarction, that LDL is causally related to atherosclerosis, and there's enough evidence, as you can see on the slide. Now, when we look at the science of lowering LDL during the last 25 to 30 years, what are the big messages? Message number 1, can we stabilize the plaque by lowering LDL? The answer is a big yes. Lots of trials are available from statin therapy. The second issue, can we reduce the plaque buildup? Again, the answer is yes, which means we can arrest the progression of atherosclerosis. And we had the reversal trial, which very clearly shows atorvastatin produce arrest of progression of atherosclerosis compared to Prava. And remember, this arrest of progression occurs at the level of LDL which is less than 70. So if you want yourself, your atherosclerosis should not progress, you have to persistently keep your LDL below 70, which is not difficult even with statin. Can we shrink the plaque by lowering LDL? Answer again, yes. We have the GW trial, which shows that atherosclerosis can be regressed when you combine statins with evolocumab, a PCSK9 monoclonal antibody. And remember, this will occur when your LDL is slashed down to less than 50. So if you keep your LDL less than 50, you are very unlikely to develop acute myocardial infarction because atherosclerosis, what was there, has already regressed. And lastly, can we make the plaque disappear by lowering LDL? This is still an unresolved issue, but we do not know it may come out to be true in times to come. The other thing you have to remember if you want to get yourself free from AMI is all levels of LDL are atherogenic. All levels of HCl are atherogenic. I'll show you the data. So that this is the data from the Fourier trial subgroup analysis. You can see even when LDL is less than 10, there's incremental benefit without any safety concern on the this side. So even lowering LDL to 10 has been documented to be safe. You can see side effects hardly present. Both the bars are at the same level. And again, the guidelines usually say for a healthy individual, keep your LDL 100, some say 130. But you have to remember, even when you are keeping your LDL 100 or 130, which are generally regarded as normal, they are also at risk of MI. So if you want to prevent MI, what you should do? You have to understand two basic concepts of atherosclerosis. One, just like cigarette smoking, cumulative LDL burden. How do you calculate cumulative burden? It is cumulative exposure of LDL, which is very important. Circulating LDL into the years of exposure. Suppose your LDL is 100, your age is 70, 100 into 70 becomes the cumulative. CHD threshold is very important, and the threshold at which CAD gets manifest and produce acute myocardial infarction is 7,000 milligram years. And AMI only develops when the cumulative exposure of LDL to the arterial wall reaches the threshold target of 7,000 milligram years. Please switch it off, switch it off. And this shows the importance of cumulative exposure of LDL burden. If you are a patient of HEFH and your LDL is 230, you will develop MI at the age of 30 years, because you divide 7,000 by 230, it comes to 35. If your LDL is 100, this is to be long, whole life after 20 or so. If your LDL is 100, you will develop MI at the age of 70 years. 7,000 divided by 100 becomes 70. Your LDL lowering to 70, you will develop MI at the age of 100 years. So, and this has to be persistently lowered right from early age. And this beautifully demonstrates the concept of cumulative exposure. Have you got a pointer? Beautifully demonstrate the cumulative exposure. So if you can see here, if you are a patient of homozygous FH, LDL is more than 560, here is 560. If you divide 560 by 7,000, these patients develop MI at the age of 12.5 years. If you are a patient of HEFH, red one, usually LDL is more than 200, and these patients will develop MI at the age of 35 years, the red line. But suppose these patients start even low dose statin at the age of 10 years, what will happen? They will develop MI at the age of 53 years, the dark blue line. So suppose they start high intensity statin at the age of 20 years, the benefit is less. They will develop MI at the age of 48 years. So starting statin very early in life is very fruitful, rather than starting statin, even high intensity statin at a late age. So how we can prevent the individual to reach the CHD threshold, and this is an effective solution to prevent acute myocardial infarction. The most fantastic advancement in this field is gene editing by CRISPR technology. And in this, the double-stranded break is produced at the genomic target, and on healing, the gene loses its function. So that if you target PCSK9, the PCSK9 will lose function, you develop loss of function of PCSK9, and with a single sitting, your LDL will be stretched down to 30 or 40 for the rest of life. And the first patient in New Zealand has already undergone PCSK9 gene editing few months back. More must have been done, and the hard-won trial with GW-101 is ongoing. And the credit to gene editing goes to these ladies, Emmanuel Carpentier and Jennifer, who were awarded a Nobel Prize in Chemistry, a fantastic technique. The other modality could be statins, inclisiran, PCSK9 monoclonal antibodies. Statins, and the other thing you have to remember is your vision for prevention MI should not be a tubular that you only look at LDL, because some other factors can slash down this threshold for myocardial infarction with 7,000 milligram. Yes, suppose you are having a lot of saturated fats, you have salt and hypertension, you have sugar and diabetes, smoking, stress, sleeplessness, and sedentary. If these factors are there, you have to control these. Otherwise, the 7,000 line may come lower. Statins can be utilized, and all of us know statins can easily bring down LDL to less than 70, but the problem is you have to take it daily, regularly, for many, many years, and they are very safe agent. PCSK9 monoclonal antibodies are good, but you have to get injected every 2 weeks or every month. Inclisiran, once in 6 months, is a beautiful drug, but very, very costly. And if you analyze the data of the Orient trial, 300 milligram inclisiran given, it slashed down the LDL to 50%, that remains there for 6 months. But if you notice on this line, when you give LDL at the end of 1 year, it is 20% below the baseline. So a cost-effective approach could be when you inject inclisiran every yearly even, it will come down to 30 or 40%, which could be sufficient for prevention of MI. The concept is emerging that if LDL can be practically reduced to less than 70 on a population-wide basis, this will postpone development of myocardial infarction by several years, and this concept is being tested in United Kingdom. The other evolving therapies is the PCSK9 vaccine. A single vaccine decreases LDL by 50%. This remains there for the next 1 year. And the human studies are ongoing, and if this comes out to be positive, a booster dose every year will be the new way to target to prevent acute myocardial infarction. Gene editing, I already told you, is a fantastic technique, and gene editing is the big stake because once and done, you don't have to come back on a single time, and I'll show you the video. CRISPR-Cas technology has two components, a guided RNA which guides where to cut the gene, and the Cas9 which executes the gene cutting. So the CRISPR is composed of these two components. The guiding RNA guides the Cas9 protein to the specific genome target, where the Cas9 nuclease induces a double-stranded break at the specific genomic target. So this is the video. You can see the guiding RNA will guide the Cas9. C is guided. The gene has been cut. PCSK9 gene has been cut. And when it heals, what will happen? It will lose its function. So single time technique, you will see it has become red. This has lost its function. You become a candidate with loss of function mutation of PCSK9, which is acquired, and your LDL will slash down to 30 or even less than for the rest of life. So this is a procedure which is done once and is there for the rest of the life. We usually give our patient a health mobile number for preventing MI, 13080700700. And what does it stands? 13080 stands for lowering blood pressure, systolic 130, diastolic 80. 70 is for LDL, less than 70. Arrest progression of atherosclerosis, 7 for HbA1c, and 000 for smoking. The concept is being widely studied, and look at the comments of Dr. Braunwald, how to live 100 years before the developing clinical coronary artery disease, and you will know the LDL of our respected Dr. Braunwald is 30 milligrams. And Dr. Narula is 35, and all of them are very elderly and living a very healthy life. Dyslipidemia over a lifetime is a case for early intervention LDL. So the concept emerging, you should prevent cumulative exposure of LDL. It's not that you start during high intensity 10 age of 30, 40, you are symptomatic with coronary artery disease. It will be useful, but may not be to that extent. And what is the simplest test? You are prone to acute myocardial infarction. There's a big question mark, but the simplest test is sexual health is an indicator. So if you are able to perform, your endothelial function is good, you are less likely to develop myocardial infarction. But the problem these days all over the world is the digital intoxication is emerging as a big barrier to healthy sexual life. Smartphone, WhatsApp, Google, Face, Instagram, Twitter, LinkedIn, Tinder, Snapchat, all these are making people busy and is interfering even with their sexual life. So the message is, do a digital detoxification by doing fast without social media and at least twice a month, and not the conventional fasting. This fast is more important these days than the conventional fasting. So we have excellent modalities of treatment for acute myocardial infarction, lifestyle modification, OMT, PCI, CABG, but all these modalities do not decrease the number of patients of acute myocardial infarction. They are increasing every day. So our aim is to build a heart attack-free India, stop heart attack, stop heart attack, stop heart attack, and the way to do is primordial prevention. Prevention, all of us know, is prevention of emergence of risk factors in population. They have not yet appeared by individual and mass, and the best candidates are the nursery children. And it is seen if these children are taught a healthy lifestyle, they continue to follow the rest of the life, and has appeared from data from the familiar trial, other data from the vector Valentin Fuster from Spain. So conquering this impossible should be our destination. Living up to 100 years without MI is a possible task. It's based on current science. You have to just lower LDL to less than 70 from young age. This will arrest progress of atherosclerosis. If you lower it to less than 50, still better, it will regress atherosclerosis. So if all of us follow the current science from early age of 20s, at least in Indians where we see, or even 30s, it will enable hearts to beat without blockage for 100 years. Keep your LDL less than 70, preferably less than 50 from early age to the rest of life to remain free from myocardial infarction. Thank you very much for your kind attention.